Friends, in this series of ECG basics, today I will talk about QT interval. First is the disclaimer. Caring Docs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information available on this channel is for educational purpose only, and it should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. QT interval, it is time from the start of the Q wave to the end of the T wave. It represents time taken from ventricular depolarization and repolarization, effectively the period of ventricular systole from ventricular isovolumetric contraction to isovolumetric relaxation. QT interval is inversely proportional to the heart rate. It shortens at faster heart rates and it lengthens at slower heart rates. An abnormally prolonged QT is associated with increased risk of ventricular arrhythmias, especially the Torsades de Pointes. Congenital short QT syndrome has been found to be associated with increased risk of paroxysmal atrial and ventricular fibrillation and sudden cardiac death. How do we measure the QT interval? The QT interval is usually measured in either lead 2 or lead V5 or V6. However, the lead with the longest measurement should be used. Several successive beats, they should be measured with the maximum interval taken. The large U waves, which are more than 1 mm, that are fused to the T wave, they should be included in the measurements. But the smaller U waves and those that are separate from the T wave, they should be excluded. The maximum slope intercept method is used to define the end of the T wave. In this ECG picture, the left ECG and the middle ECG, here the smaller U waves and those that are separate from the T wave, they should be excluded from the measurements. And the ECG on the right side, here we can see large U wave that are fused to the T wave that should be included in the measurement. So the QT interval is defined from the beginning of the QRS complex to the end of the T wave. The maximum slope intercept method defines the end of the T wave as intercept between the isoelectric line with the tangent drawn through the maximum downslope of the T wave, as we can see in the left. When the notched T waves are present, for example the right sided ECG, the QT interval is measured from the beginning of the QRS complex to the intersection point between the isoelectric line and the tangent drawn from the maximum downslope of the second notch. The corrected QT interval estimates the QT interval at standard heart rate of 60 beats per minute. This allows the comparison of QT values over the time at different heart rates and improves the detection of the patients at increased risk of arrhythmias. There are multiple formulas which are used to estimate the corrected QTC, and it is not clear which formula is most useful. For example, we use Bazet formula where the QTC is QT divided by square root of RR interval, Fredericia formula where the QTC is QT divided by RR 1 by 3 RR, and Framingham formula where QTC is QT plus 0.154 into 1 minus RR interval. Hodges formula where the QTC is QT plus 1.75 heart rate minus 60. So the RR interval is given in seconds and it is 60 divided by heart rate. The normal QTC values in men, if it is more than 440 milliseconds, then we say the QTC is prolonged. However, in women, if it is more than 460 milliseconds, then we call it as QT is prolonged. The QTC, if it is more than 500 milliseconds, it is usually associated with increased risk of Torsades de Pointes. So QTC is abnormally short if it is less than 350 milliseconds. A useful rule of thumb is that normal QT is less than half of the preceding RR interval. What are the causes of prolonged QTC? Means more if it is more than 440 milliseconds in men and more than 460 milliseconds in women. The causes are hypokalemia, hypomagnesemia, hypocalcemia, hypothermia, myocardial ischemia, ROSC, post cardiac arrest, raised intracranial pressure, congenital long QT syndrome, and medication and drugs. ROSC is restoration of spontaneous circulation after the post cardiac arrest when we give CPR. Then after CPR, when there is restoration of the spontaneous circulation, we call it as ROSC. In this ECG, we can see QTC is 510 milliseconds, and it is seen in patient with hypomagnesemia. Similarly, here the QTC is 510 milliseconds due to hypocalcemia. Hypocalcemia usually prolongs the ST segment, leaving the T wave unchanged. This is the ECG of patient with hypothermia. Here the QTC is 620 milliseconds, and patient has severe hypothermia. It causes marked QTC prolongation, often in association with bradyarrhythmias, especially the slow atrial fibrillation. And we can at times get Osborne waves and shivering artifacts also. This is the ECG of a patient with myocardial ischemia. Here the QTC is 495 milliseconds due to hyperacute MI. Myocardial ischemia usually produces a modest increase in QTC, that is in the range of 450 to 500 millisecond range, and this may be helpful to distinguish hyperacute MI from the benign early repolarization, as both these conditions produce the similar hyperacute T waves, but in benign early repolarization it usually has a normal QTC. This is the ECG of the patient with raised intracranial pressure. Here the QTC is 630 milliseconds with widespread T wave inversion due to subarachnoid hemorrhage. A sudden rise in intracranial pressure, that is due to subarachnoid hemorrhage, may produce characteristic T wave changes, that is cerebral T waves, and that is widespread deep T wave inversion with prolonged QTC. Coming to congenital long QT syndrome, the QTC is more than 550 milliseconds, mostly seen in congenital long QT syndrome. There are several congenital disorders of ion channels that produces a long QT syndrome, and they are associated with increased risk of sudden cardiac death and Torsades de Pointes. The causes of the short QTC: when the QTC is less than 350 millisecond, we can call it as a short QTC, and the causes are congenital short QT syndrome, hypercalcemia, and digoxin effect. In hypercalcemia, in the ECG, we can see there is shortening of the QTC, that is 260 milliseconds, and this hypercalcemia also causes shortening of the ST segment, and it may be associated with appearance of the Osborne waves. So Osborne waves are seen in hypothermia, hypercalcemia also. Congenital short QT syndrome, here we can see very short QTC, that is 280 millisecond with tall peaked T wave. And this congenital short QT syndrome, it is an autosomal dominant inherited disorder of the potassium channel associated with increased risk of paroxysmal atrial and the ventricular fibrillation, and sudden cardiac death. The mean ECG changes are very short, QTC in the range of 300 to 350 milliseconds with tall peaked T waves. How do we come to know the presence of short QT syndrome? Presence of short QT syndrome may be suggested by the presence of lone atrial fibrillation in the young adults, family member with short QT interval, family history of sudden cardiac death, ECG showing QTC less than 350 milliseconds with tall peaked T wave, failure of the QT interval to increase as the heart rate slows. So in this ECG we can see very short QTC with peak T wave in two patients with short QT syndrome. The patient on digoxin, we also see short QT interval, and digoxin actually produces a relative shortening of the QT interval along with downward sloping of the ST segment, depression in the lateral leads. This is a reverse tick appearance where we get widespread T wave flattening and inversion and multitude of arrhythmias. And these arrhythmias can be ventricular ectopic, atrial tachycardia with blocks, sinus bradycardia, regularized AF, and any type of AB block. This is the QT interval scale. It was designed by Wiskin in 2009. He proposes the use of QT interval scale to aid the diagnosis of patients with short and long QT syndromes once the reversible causes of QT prolongation or shortening have been excluded. So this scale is useful in diagnosing the patients with short and long QT syndrome. But first of all, we have to exclude the reversible causes of the QT syndromes. So here we can see in both males and females, when do we say very long QT? See, if it is more than 470 in males and more than 480 in females, even if the patient is very asymptomatic, we have to exclude the secondary causes. Long QTC is when QT interval is more than 450 in male, 460 in females, and if there are patient has symptoms, we have to rule out the family history and we have to do some additional test also. So if the long QT is possible, additional tests are indicated, for example repeat ECG, Holter T wave morphology, exercise epinephrine challenge, adenosine challenge test. So the normal QT is 360 to 370, 370 in female and 360 in male. Short QT is when it is supported by the symptoms, when the patient has family history of, then if it is less than 330 in male and 340 360 in male and 370 in female. For normal QTC is 390 to 400, 390 in male and 400 in female. And if it is less than 360 in male, it is short QT. If it is less than 370 in female, it is short QT. And when it is supported by symptoms or when there is family history, then we have to do additional tests like repeat ECG, Holter T wave morphology, electrophysiological studies may be needed at times. And very short QTC is when the QT interval is less than 330 in male and 340 in female. And even if the patient is asymptomatic, we have to rule out the secondary causes. Observation, reasons, human understanding, courage, these makes the physician. It was said by Martin H. Fishner. With this, I conclude my today's topic. Thank you. Keep learning.